And so welcome everyone. Before we get started, we do have some exciting news. Since our last webinar, we have hired a new director for our Native Center for Disabilities here at the Sonoran USAID. And she just started this week, and she wasn't able to join us today, but we do have a recording and message from her introducing herself, and she'll be joining us in our next session.
I'm really excited to be here, and I'm really excited about this position and working with everyone. I've been working in higher education for about 12 years. I did 3 years in tribal colleges and universities. I'm also a PhD candidate at the University of Arizona. So I'm working on the last phase of my dissertation research, which focuses on Native American Indian women in leadership at tribal colleges. So I was able to use talking circles, and as part of being a graduate student, I was a fellow with the Sonoran USAID. So that was a really fun and exciting partnership that I got to work on. So yeah, I'm excited.
We are really excited to have Christy Kelly join us as our director. And as she mentioned, she was previously a diversity fellow with us here at the Sonoran Center in our inaugural cohort several years ago. And it's great to have her back here with us at the USAID. And so today, I'm excited to turn it over to our speaker for this session, Jim Warne. He'll be discussing Indigenous perspectives of disability. And, we're fortunate to be working closely with Jim as he's helped us to launch our new Native Center as a sister center of the Oyate Circle that was started in South Dakota with the USAID there. So Jim, I will turn it over to you.
Thank you so much. Palamia Washtelo, JC. And again, welcome everybody. I see old friends and new friends on the list here of names of participants. So welcome and thank you for joining us today. As JC said, we are a new Native Center. We're in our first year, and now Christy is our new director. So she is the face of our Native Center at the Sonoran Center for Disabilities at the College of Medicine in Tucson. But we have site offices throughout the state. We plan to have individuals and partners and collaborators that we work with at various reservations and tribal nations throughout Arizona, as well as hitting the urban areas, because we know that Phoenix, Tucson, and Flagstaff and other municipalities have a high population of Native people. So Wayne and I, Wayne Weston is Christy's counterpart in South Dakota at the Oyate Circle. And Wendy Parent Johnson, who is now the executive director of our USAID in Arizona, was the executive director at South Dakota. So that's where our paths crossed, Wendy and I. And she had a vision of creating something within the USAID system that addressed our indigenous populations, in particular, the Lakota, Nakota, and Dakota tribes in the South Dakota region. And so she convinced me to come back to academia, which I'm so happy that she did. And we created the Oyate Circle, which is kind of a sub-center under the umbrella of the University of South Dakota Center for Disabilities at the School of Medicine there in Sioux Falls. So we're very fortunate to be able to have not only the support from the USAID, but we were able to write grants and get contracts and create a nice solid foundation for the Oyate Circle that we're going into our 5th year here pretty soon, which is very exciting. And in that short 4 years that we have been operating, Wayne and I have been able to cover all 9 reservations in South Dakota and get thousands and thousands of miles of res hopping, I call it. And that's something that's unique, I think, for many of the you said, is to have that presence in those tribal communities, in particular rural reservation communities. With Arizona, it's a whole new different perspective with Arizona tribal nations. As mentioned, we're down in TO country, Tohono O'odham country, and Yaqui country in the southern area of the state. But there's many tribal nations in Arizona. So obviously, I think many are aware of the diversity of Indian country, but there is a great diversity of Indian country in Arizona, not only with the 22 tribes, but with the urban Indians like myself that grew up in Tempe, Arizona as an Oglala Lakota tribal member. I was born in Phoenix, so, and grew up with a lot of Arizona tribal members as friends. So I'll go in and please let me know if this is working regarding sharing my screen, and hopefully everything's good there. So just yell at me if it's not. So I'm going to move this over as well. Okay, so I wanted to address Indigenous perspectives of disability with you today. And again, this is a unique perspective when we're viewing disability as a term. None of our Indigenous languages have a word for disability. So we do the best we can, particularly with our traditional folks. And in South Dakota and Arizona, there's many English second language folks that we need to outreach and kind of explain in the traditional Indigenous perspective of what is a disability. So that's something that I've learned over the years as working in various tribes in Arizona and South Dakota, as well as throughout the nation, the diversity of Indian country and the diversity of perspectives of disability from the various tribal nations. So there's no one homogenized version, if you will, of disability in Indian country. It's kind of trying to find out what that particular tribal perspective is. Navajo is going to be different than Lakota country. So those are some, comparatives. And then as well as the differences within the tribes in Arizona are unique in and among themselves. So I'm Oglala Lakota. Many people know us as Sioux, the Great Sioux Nation, but I'm the Oglala band of the Lakota. So again, we have clans in Arizona. We have bands up in our area and the plains. And I work with Warrior Society Development, and I want to create warriors in whatever capacity in the world of disability or education or anything that empowers Indian country. And disability, I'm really focused on because of my father, Jim Sr. He had MS for 37 years. And as a young person, I grew up with him with a progressive disability. And that really taught me what true strength was, viewing him living with disability, MS in his case, and still working as long as he could. So that's why I'm a big fan of vocational rehabilitation and the empowerment services that they provide for Indian country. So I wear many hats. So I'm part-time director of community engagement and diversity at University of South Dakota Center for Disabilities. As I mentioned, we were able to create that, and now Dr. Eric Kurtz is the director, and we're very fortunate that he took over for Wendy and had the same commitment and value for Indian country in South Dakota particularly. When we're about 10 or 11% of the population of South Dakota when you look at tribal enrollment numbers. So obviously we need to have services for folks there in South Dakota addressing Indian country. And now with Wendy in Arizona, we were able to partner again, and it's wonderful to be back working with my Arizona friends. So greetings to my Arizona crew from the old days when I was working at Pet Air and those old programs. So it's a pleasure to be back working with Arizona tribal nations. So I'm going to be addressing my family. This is kind of a traditional way, as we always introduce ourselves through who we are as family. So this is my grandfather Stabber that was at the White House with Red Cloud, negotiating peace with President Grant. So it's it's nice to have these photographs and the stories of our grandfathers. And in this case, it's wonderful to know that Grandfather Stabber was doing what he could to leave good footprints for for future generations. So we still acknowledge him today in our family. And you see here, he lived to the age of 70 years old. So he had a long life. And unfortunately, the average life expectancy on Pine Ridge in particular, my home res, is 48 years old for Indian men. So that is a public health crisis. Hopefully we're able to do something to correct that. And here's who I'm named after, Grandpa Tushunko Kawachakte, which is kills on horseback. So this is my grandfather that my mom remembers growing up with him drumming every morning and every evening with the sun coming up and the sun coming down. He would sing songs to let the kids know it's time to get up or it's time to come home. And then there would always be a message and a story to those songs, because that was a traditional way of learning and teaching through those stories so that the kids could gain problem-solving skills, critical thinking, information of the day that he felt was important for the young ones, as well as the other families to know. And here's my Unchi, Grandma May Stabber Featherman, excuse me. You see her here with the horse in full regalia and holding an infant. And so we were celebrating a newborn, but unfortunately that infant did not make it. And that's still a challenge today, unfortunately, in 2022, is the infant mortality rate that we have back home on Pine Ridge, as well as other reservations throughout the nation. My mom and dad getting married in Rapid City, South Dakota. So unfortunately, back in the early 60s, there were still no Indians allowed signs in restaurants and housing. So we ended up moving to Arizona, and that's where I was born and raised, in Arizona. But we would always go home to Pine Ridge. Mom wanted to make sure we knew who we were as Lakota. So here's me as a baby with Grandpa Louie holding me and Grandma Eva. And you see the military Quonset hut behind there, where often the abandoned military Quonset hut and materials would be used by reservations, so for housing, and that's where many families live back there. So this is home in South Dakota. Pine Ridge Reservation is close to Rapid City, the Black Hills. Many folks know Mount Rushmore or Crazy Horse Memorial out that way. So we're very close to our traditional homelands with this particular reservation. And you see our relatives, the Sichangu Rosebud over there, their reservation nearby as well. I'm showing this. This is a boarding school where my mom went to school in the 40s. And so this is an Indian boarding school where children were often forced to go to these schools. So many families would move and camp near the school so they could be near their children. This is Oshkosh Camp. We called it Indian Camp in Rapid City, South Dakota. And this is where Native people were allowed to live just by the creek right outside of town. So this is where Mom remembers growing up in these tents and other makeshift wood structures where the Lakota people would live so they could go to school or work at the lumber yard or in the kitchens. My mom grew up washing dishes for many years as a young person. And here she is now, 60 years as a nurse. And it's wonderful that she's still with us today at 83 years old, and she still teaches at South Dakota State University. And she created the Native American Nursing Education Center. And it's really been successful as a hub and a place where Native nurses can gather and have that support so that they can have the Indigenous perspectives of learning, as well as support for their collegiate classes so they can pass and graduate. So when Mom started at South Dakota State University 5 years ago, there were only 4 Native nurses. Now there's over 40 Native nurses. So Mom's doing great work still today. So I acknowledge her, and she's working at South Dakota State, and I'm at University of South Dakota with the Oyate Circle, as well as my brother. I just came back from North Dakota, where I keynoted a wonderful summer program of Indian youth. And I'm proudly wearing this necklace because one of the kids that was one of the attendees of the summer camp for Indians in the Med School. And there were kids from Hopi and Navajo and other Arizona nations as well. So that was a great experience. So this is my mom's program, and this is kind of the Indigenous perspective of nursing that she applies so that those students can be successful, and it's incorporating our traditional knowledge and things of that nature. So again, it's following the process of nursing, but it's utilizing Indigenous ways of knowing our Indigenous knowledge so that it's applicable and supports the nursing students. So I followed Mom's lead as an academic at San Diego State. Many of you might remember the Center for American Indian Rehabilitation and Education at Interwork Institute. I worked there for 25 years. And it was wonderful to have the Pet Air program. I think some of my former students, survivors of Pet Air, I like to say, but they were able to earn their certificates, and many use these certificate units to transfer into their master's and doctoral programs. So I was very proud of this program and the work that we did with Indian country, focusing on tribal voc rehab. Now with Oyate Circle, as I explained earlier, Wayne Weston, my Tahanshi, and I are working with our tribes, not only in South Dakota, but this is starting to become a national program. And now we have our sister program, yes, in Arizona, the Native Center for Disabilities. So this is very exciting. And now Christy is the director for the Native Center. And we also got another grant for youth transition. And so that's the Finds Their Way program for our youth transition. So we have already one grant under the umbrella of our Native Center for Disabilities that Christy will also be administering with other staff for the youth transition. And then the Native Center for Disabilities will be that hub, if you will, for other grants, contracts, and curriculum development and support services that we'll be developing in Arizona as we get started. So many of you in the audience will already collaborating with when you think of the youth transition program and our partnerships we're developing with not only the tribal nations, but with our other programs out there that want to better serve tribal members with disabilities, whether they be adults or youth or elders. So we want to be an all-inclusive, universally designed Arizona Native Center. So we want to focus obviously on the Arizona tribes, but also be inclusive and be pan-Indigenous. My Tahanshi Wayne Weston often says, we must be pan-Indigenous and all work together as tribal nations. We can't think like reservations, we need to think like nations. So that's something where I think we're moving ahead as the next generation impacts Indian country. I want to acknowledge Treva Roanhorse. She's one of my mentors. When I was fresh out of my master's degree in 1993, I visited Navajo Nation OSERs and voc rehab. So I was able to learn a Native approach from the Navajo perspective in disability services from a not only vocational rehab perspective, but special education as well. So Treva's part of our team with the youth transition program, and she'll be mentoring Christy as well as other folks and providing her support wherever she can for our program. I was honored with the Susan M. Daniels Disability Mentoring Hall of Fame last year, and that was a wonderful honor that I accepted in honor of my dad, Jim Sr., because he's the reason why I work in disability. And those who knew Susan know that she was a great advocate for disability communities. So that was a great honor for me to do that. Many of you may know that I'm also a part-time filmmaker. This was my last film, Oyate Unituwapi, which was pictures of my people that I did with the NFL and Fox Sports for social justice. So that was wonderful to be able to make that film. And we're announcing our new film that's releasing next week. We're having our local premiere in Rapid City, South Dakota. And so Remember the Children is about the boarding schools and the things that happened in those boarding schools, because thousands of children unfortunately died and were left in unmarked graves. And with modern technology in Canada and in the United States, we are now finding many of those children, those lost children so we can honor them and bring them home. So again, transitioning back into the healthcare arena, when you think of disability and how does healthcare impact that, it is unique that we as tribal members are the only population that have a legal right to healthcare. But unfortunately, Indian Health Services was funded at 60%, but with some of the new administration's laws and regs, there's now going to be a little bit more funding. So hopefully we can get into the 70% range of funding for Indian Health Services. And we have that right through Constitution, trust responsibility, but we still have that challenge, as I often reference, that Native culture and disability culture often intersect. When you think of both of the cultures are fighting for that self-determination, as well as that inclusion in society, I think both of our cultures have those challenges. And as a result, I think Indian country and disability culture can work together in a good way to make impact and hopefully increase some of these shortages that we have, not only in the healthcare fields, but in the disability services as well. So what is disability? As I said, we don't have a disability term, but consider, what is your perspective from English speakers? What is disability? Just think about it for a moment, because many of us work in the field of disability, but what does it mean to you personally? What do you envision the culture of disability as when you think of it yourselves? If you like, you can share in the chat what you feel, what is disability in contemporary American culture. But when you think of your perspectives, obviously many of us work in the field. So my perspectives were obviously impacted by my dad. So Jim Sr., Pops, he taught me what disability was from a multiple sclerosis perspective, and then eventually with the mobility and wheelchair issues that he had to go through and live with. So the Americans with Disabilities Act was a great day for disability culture, because it was the civil rights essentially for people with disabilities so that they could be included. Similar to the civil rights of 1968 for American Indians, which was a follow-up to the civil rights for American citizens in 1964. So as you see, it's very important to be involved in the federal systems, because we need to make sure we have federal law protecting people with disabilities, as well as tribal sovereignty and tribal rights within contemporary America. So when you think of healing and culture, Chief Joseph, one of the leaders from the Northwest, stated, treat all men alike, give them the same law, give them an even chance to live and grow. So again, we want to treat all people alike, men and women. And that's essentially what ADA was for people with disabilities, was addressing equality and then equity. So equality was everyone gets the same services, and what happens? So someone's left out. But equity is we adjust those services to address the underserved populations. So when you look at now, we want that liberation. Why have the fence? Why have the barrier at all? And that would be the universal outcome of design physically, as well as inclusion from a societal aspect, that we could all be included no matter what the situation was. Again, with healthcare in Indian country, we have that legal right. But when you look at the treaties, the Bureau of Indian Affairs, which is wonderful, now that we have a first time ever in this administration, Deb Haaland, Secretary Deb Haaland, is a tribal member, and she's been doing great things as the first Secretary of the Interior. So she has a lot of challenges, but finally, I think because of her voice, this administration is including Indian country much more than other administrations have in the past. And then of course, Indian Health Services, we'll see what the new funding does and what the impacts are as a result of the pandemic. So again, when you look at these comparatives, here's Indian Health Service, Bureau of Prisons, Medicaid, Veterans, and Medicare. And this was an average back in 2005 per patient. But when you look at Indian Health Service at 2,000 per patient, it's interesting that that's half of Bureau of Prisons. So again, if we doubled Indian Health Services funding, this is old, so hopefully we're getting closer to our prisoner level of funding. And wouldn't it be wonderful if Indian Health Service was equal to Medicaid or veterans? That would really be a wonderful outcome and increase services for Indian health. And then you see the disparities of health in South Dakota when you look at American Indian versus our Euro-American brothers and sisters. In this case, in South Dakota, the average age of death for non-Indians is 81, but 54 for tribal members. So obviously there's something going on there, and we need to address these issues because the suicide and the accident rates and some of these other challenges are producing higher rates of disability as well. And I want to address some of the mythology of alcohol use in Indian country. We see here on in the circle that the hard drunks, you see the hard drinkers, the stereotypical drinking person in terms of in the streets and having trouble. You see that breakdown of the non-drinkers and the people in sobriety. But when you look at on the reservation, the most sober population is living on the reservation. I think from a personal perspective, this is some research that my brother did in alcohol use, that many of our traditional ways, many people that live on the reservation are utilizing the traditional perspectives and indigenous knowledge to stay sober and to stay away from the disability of substance dependency. So again, I think with that cultural aspects that many of our programs incorporate, that's why we're being successful, not only with Oyate Circle, but what we're building in Arizona with the Native Center as well. So again, these are various challenges that we're having in Indian country. When you look at the age of death and things of that nature in high school, dropout, poverty rates, suicide rates, unfortunately, every day in the South Dakota reservation, a young person is attempting suicide. Fortunately, they're not all successful, but many end up with disabilities as a result, and we need to be prepared for those young ones with disabilities also. And then when you think of trauma in Indian country, and resilience is what I really like to focus on, and why do people have to be resilient is because there's many challenges that we must face. So when you think of trauma, the cultural trauma, when you think of our languages and our ways that are not understood or not included in our service provision, historical trauma, when you think of what happened in the past, that intergenerational trauma, the unresolved trauma from past generations, when you look at that intergenerational trauma that's now scientifically proved with many medical schools and studies of the impacts of intergenerational trauma. And here's a nice design that I got from Dr. Bigfoot that shows some of the aspects within those circles and those connected circles of oppression, poverty, as well as historical events. When you look at the accidents, the violence, child neglect, domestic issues, suicide, dependency, incarceration, all of that is collective aspects of trauma getting right into the middle of that circle. So again, with the circular perspectives, often from Indian country, that's another reason why we have talking circles, why we have Oyate Circle, as we want to incorporate the culture and that indigenous perspective, in this case for disabilities. So again, I see a lot of chat questions. Just interrupt me, JC, if I am missing anything important, or we can just answer them at the end as well. I will allow some time for questions. So here's a difficult history. I'll just kind of go through this quick, but there's a reason for trauma and resilience. And again, that historical intergenerational trauma, when you look at genocidal rates, many people think there were only 5 million people here in what is now America. I think it was closer to 20 million. Some people have even higher estimates, but let's go with 5 million. We're now getting close to where we were prior to 1492. So again, in 1492 was Columbus, And then when you see that transition in these areas of time over the years, and then where we are now with just 4% of the land, but our population is growing now instead of reducing as a result of some of the genocidal aspects of the history. So 1492 was all native, if you will, in what is now America. And then Columbus discovered the Caribbean. Just so that you know, Columbus never did step foot in what is now America. It was South America and the Caribbean areas that he found himself in and renamed the West Indies when he was looking for India. The colonial period, when you think of the colonial and the UK impact and what happened with Amherst, all you have to do is Google Amherst, Sir Geoffrey Amherst, and he was the colonial governor of the area that authorized and ordered a pandemic, infected blankets with smallpox in order to utilize germ warfare in the wars there. And this is some of his correspondence with his military leaders at the time. 1830 to 1850, that was President Jackson removal. Trail of Tears is what many people hear about, but there's still some of the tribes that were able to stay in their traditional areas. Seminole hid out in the swamps, the Cherokee up in the mountains of the Carolinas, and then you have some of these other tribes, but many of them were indeed marched to what is now Oklahoma. And then the gold rush in California, that was very impactful. And then the bounties for scalps. So you see here in various newspapers, scalp distribution total. So they were advertising how much money was distributed to bounty hunters for $25 scalps. In this case, here you see the scalps were increased to $200 per scalp for every redskin sent to purgatory. So this was the bounty that was listed right under after the election outcome, and then they advertised the increase in scalp rewards. So 1890 was Wounded Knee. That's very personal for me because I have family buried at Wounded Knee of 300 people. On this headstone, my family is listed, the number 18 family there. I have 3 family members that we're aware of that are buried in the mass grave at Wounded Knee back home on Pine Ridge. So unfortunately, here's an example of a mass grave on the left of your screen in Europe, and then there's the mass grave at Pine Ridge. So I'll never know which of those bodies are family members, but I always, when I go home to acknowledge them so they're never forgotten. So here's the manifest destiny approach when the angel is pushing tribes and buffalo and other wildlife away for the expansion of Western civilization. Last month, my Ta-Nehisi Wayne Weston had this image, which I really enjoy and like. But this is where we're all related. We're going to come back and bring some of that indigenous knowledge with our non-Indian brothers and sisters and see what we can do to work together. So that was a great way to end the last month's webinar in terms of what can we do to work together in order to make not only Mother Earth, but all of us as two-legged, as human beings, work together better. But here's the result. Here's Indian country now. And as you see in Arizona, there is major size reservations there. So Navajo is the largest, and then we have many big tribal nations geographically, as well as smaller ones in the area. And then many of the Arizona tribes have multi-state issues. So they have to negotiate with multi-states, like Navajo with the Four Corners is generally negotiating with 4 states. Then you have Fort Mojave along the river there in 3 states with their main tribal office in California, but the majority of the reservation in Arizona. So it's a diversity of Indian country, if you will, in Arizona. So it's very quite unique. As I go back to the map, it's very unique when you look at the border issues, not only in Mexico, but the interstate borders, as well as the urban Indian populations in the cities. So Arizona is a very unique, multicultural area for Indian country. And we're very excited to do whatever we can to not only serve all 22 tribes, but our urban Indian brothers and sisters with disabilities as well. COVID-19, we're still feeling the impacts of COVID-19 in Indian country and throughout the world, obviously, but we were really hit hard. Why were underserved populations, which of course we as tribal members fit into, why were we underserved? Why did we get hit harder with COVID? Well, I think I explained a lot of that with the funding levels of Indian Health Services, as well as just the reality that any area of poverty just has lack of access to quality health care. So that is obviously an impact for the rate of COVID-19, which hit us very hard. And in Navajo Nation as well, it was really hit hard and made national news. So Navajo Nation became the highest per capita, but now is an example today in terms of a model for other tribal nations to replicate in terms of getting vaccinations out to the community. South Dakota tribal nations, with our sovereignty rights, we had our unique ways as well with our public health checkpoints. Hoopa tribe worked with the California governor to get signs so that tribes could be protected. And then now with the Indian Health Services, note that now over half of Indian Health Service funds are 638, Public Law 638. So tribes are now starting to incorporate their self-determination and taking over those healthcare funds and make provide those services either through the tribal nation or Indian Health Services. So here's an example of the tribal president getting out there to educate and utilize whatever way to reach the public in that reservation. This is back home, one of our checkpoints at Pine Ridge. So our governor actually tried to stop us from doing this, but we wanted to do this to protect our elders and our at-risk populations, our people with disabilities. So here's Hoopa Nation, and want to give a shout out to my wife, Jill. She just won her tribal election, so now she's on tribal politics, so she's involved with that, but she's going to do whatever she can as a member of the tribal council to impact Hoopa in a good way. And then here you see some of the state signs that were provided by the state government of California to help protect the Hoopa reservation in this case, because most of our tribal areas are under-vaccinated. And a lot of reasons for that is trust of Indian Health Service because of some of the things that happened in the 70s, but also just trust of the medical services in general in areas of poverty. But fortunately, the current president, Biden, did declare Navajo Nation as a disaster area and provided more resources so that the tribe themselves could incorporate the indigenous way of addressing vaccinations and the pandemic for their people. New Mexico, of course, was hit hard, the Phoenix area, 4 times the rate. So again, these are just outcomes now that we're preparing for, not only in South Dakota, but for Arizona is post-COVID. Many people are dealing with post-COVID and having those challenges. And what can we do as disability services to address those challenges that many people are facing as a result of going through high incidence of COVID in their area? As you see here in Arizona, many of the tribal areas were hit very hard. And so many people now are dealing with post-COVID disability, we'll need to call it. Again, the medical scientific world is trying to catch up in terms of diagnosis because there's no way to diagnose post-COVID, long haul COVID, they call it yet. But we need to be prepared in Indian country to do what we can to provide those services. And particularly with Arizona, and then you see here South Dakota, we're one of the 7 states that have significant Indian populations, and we need to make sure we're doing what we can in those areas to provide adequate services from an indigenous perspective. So you heard Christy mention, and many of us use talking circles. Again, this is another traditional way of gathering data through storytelling, through culture. So then we have many of our healing ceremonies that are different throughout. We do sweat lodges back home. In fact, Wayne built a couple of sweat lodges for our partner organizations so that they would have those traditional services available to people that we were working with. So that's an unusual, you said outreach is building a sweat lodge, but that is part of community engagement and being in the community, utilizing Indigenous approaches to gathering data in this case, or in the talking circles, or having those ceremonies, whatever they may be for those Arizona tribes. And I know at Phoenix Indian Health Center, there's a sweat lodge in the back of the hospital so that traditional folks can utilize those services as well in Phoenix. So resilience, again, we have to be resilient as Indian people. We have to be resilient as people with disabilities. So that's what we have in common, is that we must always be going upstream, it feels like. But when we work together and in partnership, that we can get upstream and get that empowerment that we need through not only voc rehab, but through good school services and special education and other medically based programs that could better serve our wide variety of disabilities, not only physical, but emotional and mental disabilities that we're dealing with as well. And dependency is obviously one of those. So again, through healing and culture, Chief Seattle said, humankind has not woven the web of life. We are but one thread within it. Whatever we do to the web, we do to ourselves. All things are bound together. All things connect. And again, that's a circular, evolving, moving, spiral, whatever terms. It's just not a still circle. It's whatever we do through that web that protects the circle will impact how that circle rotates or evolves, if you will, from a traditional perspective. So again, it's nice to have some of these quotes from years ago, many generations years ago, because when you think of the seventh generation philosophy, it's we, each of us as human beings, have a responsibility for 7 generations behind, representing our past in a good way, our people, our oyate, our families, Tioshpae, you know, our communities, 7 generations ago in a good way, as well as 7 generations ahead. So many hundreds of, I mean, that's a lot of years, generations of responsibility that all of us have from an Indigenous standpoint. And that involves and includes our non-Indian brothers and sisters as well. Because when you think of European tribes, they also had similar indigenized perspectives, like introducing themselves through family connection, through tribal connection, through that indigenous way of knowing. So when you think of healing and culture, our elders, we need to utilize their skills and include them when we develop our programs. And that's what we're doing with the Native Center, is utilizing the elders from the community, as well as the traditional ways that we have. Obviously, Buffalo Country is my people. So again, with the 4-legged brothers and sisters, our water relatives, the Root Nation, all of those aspects of Mother Earth are naturally incorporated into what we do as human beings. And healing and culture, yet again, with Sitting Bull, is let us put our minds together and see what life we can make for our children. And I think all of us as human beings have this common value collectively, regardless if we're Native or non-Indian, regardless if we have a disability or not. We always want something better for our future generations. And again, there's the 7th generation philosophy that you may be thinking about, but may not think of it from an Indigenous 7 generations perspective, but from that human connection to, we want a better world for our Tarkojas, for our grandchildren. And I took this picture in San Diego, downtown San Diego, for American Indian Day, 20 years ago at least. And as you see, they just put a piece of carpet down on the cement and they danced. And I was very drawn to this young girl and the intensity that she has in her eyes and the pride she has that when she's dancing, representing her 7 generations in a good way. And I hope and pray that she is living in a good way today in whatever she chose to do as a young person. And again, that's what we all have collectively, don't we? As service providers, as human beings, what can we do for our clientele, if we want to call them that, our consumers? Again, we, from Indigenous perspectives, we call you our relatives. So in closing, Palamia, Washtelo, thank you to my relatives for listening to me today. We'll announce our next month's webinar here in the next week or so, because we want to have monthly webinars with various guests to share their perspectives on Indigenous services for disability country. So again, thank you for joining me. And JC, if you would, let me know if there's any questions and I'll stop my share. I think I did it.
Sure. Yes. So we had several just comments throughout with people earlier on when you were sharing about what disability is, and several people
Oh, good.
shared that in the chat. A question that we do have from Elvia Bustamante. She her question is, why doesn't the social services foster an adoption agency if on reservation have child rehab homes, CDH licensed homes? She's a CDH licensed home off reservation with an outside agency. Our social services on reservations is not do CDH, and I can't even get Native American children from my reservation.
And that again is the challenge when you have an organization that will just have a one approach, if you will, to service provision. And that's tough when they have cultural diversity, inclusion, often that many times will not incorporate the uniqueness of Indian country, particularly in Arizona with all the different tribes. So many times they would say, okay, we found a Native person, and maybe it would be me as a Lakota, and they go, now we have an expert in Arizona. And I would always say, no, there's no such thing as an expert because there's so many tribes. But again, that's where you need to, again, advocacy and leadership is key. Again, if you're not at the table, you're on the table, I always say. So you want to be there, and sometimes it's frustrating, and it's always a long time when you deal with either tribal politics or state politics and particular representation. But we have those federal laws, not only for Indian country, but for disability country. So again, we need to be aware of what ADA can do for disabilities, as well as the Self-Determination Rights Act that we have for Indian country, not only in education, but in our tribal sovereignty. So those are, again, big level fights. And again, keep that passion to make that change, because change can't happen until you take that first step or that first role, or whatever your situation is, leaving good footprints or wheel prints for those future generations. So keep up the good fight, as we say, and always try to bring in partners from our non-Indian brothers and sisters. You're our allies, and we need you. And when we have our non-Indian partners involved, that's when change can happen. So build those partnerships and keep advocating for those services. I hope I addressed it okay.
We have another question from Stephen Curley. What are the trends for tribal health services specific to disability and rare disease services? For example, Cherokee Nation established a rare disease committee in 2020. What can these types of committees do to assist their tribal members and families better?
Yes, and again, that's per tribal nation. So what is the particular tribal nation doing? As they mentioned, the Cherokee had that program. I know Navajo Nation has a fund for disabilities as well. And they have their own OSERS, Office of Special Education and Rehabilitative Services. So you want to find out what the particular tribe has that may have alternate funding, if you will, or a grant that addresses disabilities. It might be voc rehab, but in this case with healthcare, with the new funding coming in and the COVID money that each tribe got, we're advocating that they establish a disability specialist position for the tribe that works with the healthcare systems as well as other service providers as well. So we're trying to create something not only for South Dakota, but for Arizona tribes, to where some of that COVID money, if it's going to be wasted, let's create something where we're addressing disability and have that disability specialist that works within the tribal structure. So again, with Indian Health Services and some of those challenges, you got to find out if they got other funding in support of those disability supports so that they can maneuver through the healthcare system, but as well as the post-healthcare service provision.
Thanks, Jim. And I will say there's plenty of kudos and thank yous in the chat for your presentation today. Someone did ask about the PowerPoint being available at a later time because they'd like to share it with their family. I know the recording of this session will be available on our YouTube playlist, along with the other first two sessions we have, and I've provided that link in the chat, but we'll share more information.
Yeah, maybe we can archive our PowerPoints that we use for our webinars on our website or something. We'll figure out a way, but at least you'll have the recording of it, and then email us and we'll make sure you get it so you can utilize it. We want to, all our stuff is out there to share so that people can learn. So thank you. Palamia.
Another question from Danielle. I'm working in care coordination for Medicaid. As a non-native, do you have any suggestion to help ensure coordination to traditional tribal services to best serve the native population who are receiving services?
That's a good one. And again, it's particular. And what program was that again?
Medicaid.
Medicaid,
So
yes.
Care coordination for Medicaid.
Yes. So again, now with 638, tribes are becoming the tribes that have 638. It's interesting, 638 is now a verb. But now that we have that public law 638 right as tribal nations, some of them, we're going through it in South Dakota with my tribe to where we are doing that. So as an advocate of disability, if I ever get it, you know, whenever I have an opportunity, I'm always advocating, how can we utilize that third-party billing to build more disability services within our healthcare structure that may not be supported by Indian Health Services or other aspects of the healthcare field. So again, how can we be creative to address the disabilities? And then preventative services are huge, obviously, with the accident rates and suicide rates and you know, dependency rates and diabetes. I know diabetes, I just joined the club, if you will. I was diagnosed with diabetes last year. So now I got to change my approach there to how I look at managing that new disability. So it's that awareness and those support services that Medicaid and third-party billing, I think, could bring in with some of those. And the Indian Health Service can do this as well, but many times a lot of those get lost in the minutia of the federal bureaucracy. So again, depending on the situation with your healthcare system, those are the things that I would suggest advocating for. And it's just logical for us because we value our elders in Indian country. It's a natural value for them as traditional knowledge keepers and educators. And then many times we're always ready to support elders with their disability circumstances. So again, that's a natural value that we have that we need to really incorporate, not only for our elders, but for our young ones with disabilities too. So good question. Third-party billing's huge, and Medicaid needs to, again, the whole healthcare field would be better off if they would address disability a little bit more instead of just an after effect of the healthcare. But what can we do during the healthcare process to address disability to reduce, hopefully, the long-term outcomes and effects? So sorry for that long answer, but I hope that helps.
Okay, from Gail, we have, what will the youth transition curriculum, what may be currently pre-eds today, youth transition to employment, how do you think it will differ in delivery?
Well, we want to make sure that it's all inclusive as much as we can from our approach to pre-ed services, employment transition services. For folks that don't know the transition world, it's providing services to our youth with disabilities in school so that they not only graduate, but we prepare them for the world of work. we should be doing this with every student in Indian country, regardless of disability. But under the disability services, which many of our students have, LD or other disability challenges, those are important aspects of how can we incorporate those into our school system so that they're better available for our young ones with disabilities. So what was the last part of the question again? So I make sure I answer it.
How do you think it will differ in delivery?
Ah, yes. So again, that's another term of using talking circles and the traditional healing methods. And then when you write it up in your report, you can say we did a, a focus group, in terms of explaining it in a grant, if you will, and justifying why we're doing these indigenous approaches versus the traditional data collection survey approaches that many are not having good luck with in Indian country. But doing it through the indigenous way, we tend to get more of that storytelling and just a natural approach for our people that are more traditional in root.
So Jim, I know we're at time, but we have two more, I think, brief questions in the chat, and then maybe we can wrap up. Are
Okay.
you okay with that?
Sure.
So Candace asks, does ADA apply to reservations?
Nope, as sovereign nations, we do not have to initiate ADA. But what is cool is many of the tribes like mine, Pine Ridge, has incorporated ADA, but the challenge is due to the lack of funding, it's hard to support and, ADA complaints. So again, that's why I use the elders approach. So it's not a necessarily ADA, but that there is some sort of tribal regulation or something within the tribal structure, the constitution of that particular tribe that includes disability services and supports. And often that just takes education of tribal members of what is disability, what does it include? Many times they only think of wheelchairs or lack of vision or hearing. They don't think of the full gamut of disability and how important it is to include it in some of those tribal regulations. So as sovereign nations, we do not have to, but as tribal members, we need to advocate with our tribal council to do whatever we can to incorporate the indigenized version of ADA.
This is somewhat related, but would tribal COVID funding pay for ADA services in our national parks or recreation areas?
Ah, yes, and that's another, back home at Pine Ridge, the Badlands, we have a cooperative with we now run a national park. So we need to have the ADA obviously as part of the federal structure. And then with voc rehab services, I see Rachel there, good question. With the tribal voc rehab grants, we have to address as a tribal VR program, ADA regulations that may not necessarily be part of the tribal structure. So another aspect of ADA impact in Indian country is all contractors that build public buildings now have to be accessible off the res, but now they naturally do it when they build new buildings on the res, they'll have those required ADA accessibility building standards. So again, it's unique again for tribal nation. That's what makes Indian country so interesting, is they're not just one homogenized approach. Because I often get asked, hey, do you speak Indian? And I go, I don't know, do you speak European? Because there's still 200 languages today. So my wife speaks Hupa, I speak Lakota, and they're two different separate languages. So again, that is another reality of the diversity of Indian country and all of those tribal governments that need to be educated about disability services and inclusion.
Okay, Jim, for our final question, and then we'll wrap up.
All right.
From Tess, it seems as an American born on non-native lands, we as Americans automatically want to be paid attention to as elders when we try to help. Is there a perspective we can add to help educate the populace?
Well, again, another reality of elder value from an indigenous perspective, let's compare it to the working world. what are the value of our employees when they turn 65 in most of the corporate America? Suddenly their value is diminished because they're 65. But from an Indigenous perspective, that's when our elders are just getting started. And again, that's a different subcultural value in the world of work, vocation, if you will, for this example. But that's where, when you think of the pandemic for our elders as well in America, Indian and non-Indian, many people didn't have much value for the older people. They were more interested in themselves, and the pandemic didn't affect them, so they didn't care about the older generation. So again, that was another cultural reality that we learned during a pandemic, during crisis, is what is the value of our elders or our people with disabilities or other marginalized populations. So again, I'm so glad in Indian country that our elders are so respected. And you see that when you go to traditional communities and events where elders are honored and valued. So let's hope that happens collectively as an American population as we evolve as two-leggeds.
All right. Well, thank you, Jim. And thank you to everyone here who stayed with us all the way to the end. If you didn't have a chance, please complete our survey so we can get some feedback about our webinar series and where we might go moving forward. And so again, thank you. We'll be in touch with when the recordings are available, and we'll share our upcoming dates soon for our next in our webinar series. So thank you and have a good rest of your day and week.
Thank you so much for joining us today. Palamia, Washtelo, go make a difference.